Hello, welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Nate Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the JOP. One of the promising solutions for the rising cost of cancer care in the United States is the use of clinical pathways, which harness expert opinions to outline how optimal care should be delivered. While guidelines such as those developed by the National Comprehensive Cancer Network have been around for many years, some institutions are developing and operationalizing clinical pathways in a much more rigorous fashion to try to help control costs and ensure high-quality care. But do these pathways really lower costs? And if they do lower costs, is that coming at a price of worse clinical outcomes for the patients? Joining me today to talk about this important topic is Dr. David Jackman, assistant professor of medicine at Harvard Medical School, as well as a thoracic oncologist and the medical director of clinical pathways at the Dana-Farber Cancer Institute in Boston. He's here to discuss his paper titled Cost and Survival Analysis Before and After Implementation of Dana-Farber Clinical Pathways for Patients with Stage 4 Non-Small Cell Lung Cancer. Dave, thanks so much for joining me.
Oh, Nate, thanks so much for having me.
So, can you give me just a little bit of background on the history of clinical pathways in general, and why is there so much enthusiasm about them these days?
I think that a lot of different stakeholders within the healthcare framework are looking at pathways to potentially fill a role for a number of issues. One, I think, is that medical care is becoming increasingly complex, and we need a way to ensure that all of our best care is being delivered to the right patients in the right setting. I think part of it also is that our networks are becoming increasingly larger, not just within academic oncology where you and I practice, but just in general across the country, cancer care is increasingly being delivered within the framework of larger networks or practice conglomerations. And each of those groups wants to make sure that they are overseeing care delivered in their name broadly. And then finally, and perhaps most significantly, folks are interested in this idea of cost control. And can we define what the best practice is in a given situation for a given type of patient and start to address issues of value in a way that we can then dictate care in a most appropriate manner.
And I think it's important that people understand that we're not doing this to try to ration or reduce appropriate care, but rather to get rid of wasteful and unhelpful care as part of these pathways.
I couldn't agree more. In fact, I don't even particularly like thinking about it from a cost control standpoint. I mean, I think that the better term is resource management. And in some cases, that means, yes, we're trying to trim the fat and not use treatments that don't necessarily add additional value. But in some situations, it's making sure that our resources are being positively applied, making sure that every non-squamous non-small cell lung cancer is getting tested for things like EGFR and ALK and ROS1. How do we use pathways to positively dictate care and not just kind of trim stuff away?
No, I think that's a great point. So you're the director of the pathways at the Farber. So how did the DFCI develop the pathways that they're using right now?
As we came about this, we ultimately decided that as a tertiary cancer center, we wanted to have control over the pathways that we were going to employ throughout our network. And so in doing so, we screened a number of vendors looking for one who would give us the ability to control content, and eventually found someone who was willing and able to do that and grow with us. And so as we've built pathways, we still use an online web-based platform, but we are responsible for all of that content. What we've done is we've tasked each of our disease centers to sit down as a group and figure out, very granularly, for a patient with certain characteristics in a specific care setting, what's the very best care that we can offer a patient? Always thinking about, first and foremost, outcomes, and then secondly, toxicity, and then last and when appropriate, cost, but recognizing that it is in that order.
And from a practical standpoint, how do these pathways work from the point of care of a doctor using them?
So because it's a web-based platform, the physician, while they're in the room with the patient, or, it's any time before the actual patient interaction, would log into the system and input specific criteria things like patient stage, things like line of therapy, things like histology, but also, at least within our system, some important information that we think is also key in decision making, so genomic information. Key toxicities that we may need to avoid, for instance, in metastatic colorectal cancer. If we need to specifically avoid neuropathy, it's going to then steer the physician away from FOLFOX and towards FOLFIRI. And so I think there are a lot of granular pieces of information, both patient as well as disease-based, that then help to drive the decision.
So take me through your paper here. What was the study design?
Yep, so what we looked at was we looked at the time that we implemented pathways, and we wanted to study patients diagnosed with metastatic non-small cell lung cancer before and after pathways implementation. We chose this group because it is a fairly large group, and we looked at a year's worth of treatment. And so from the time of diagnosis to 12 months later, we looked at outcomes and we looked at cost utilization. We chose the pre-pathways group as those diagnosed in 2012, assuring that there would be at least a year of follow-up for these patients before pathways had gone into existence at the beginning of 2014. And then we looked at patients who were diagnosed in calendar year 2014, which was the year after pathways went into implementation here in our group. When we looked at the data, what we saw was that survival was preserved, that there was certainly no negative impact from the implementation pathways onto outcomes. If anything, there looked like there was a slight trend towards improvement post-pathways. And then when we looked at cost, we saw that we were saving money on the order of about $15,000 per patient over that first 12 months of care for these stage 4 non-small cell patients.
And when you went back and looked at, the differences between the 2 years, what made the difference in that reduction in cost?
Yeah, so when we tried to look at this by specific line item, the most cost savings came from chemotherapy costs. Now, let me preface this by saying that we're a little bit limited because we are a freestanding cancer institution and our inpatients are actually next door at Brigham and Women's Hospital. When we're looking at cost analysis, we're not able, at least within our own group, to get the inpatient costs. So this analysis is entirely based on outpatient costs. That having been said, when we looked at what was driving the cost savings, chemotherapy was the biggest line item for savings. And most specifically, when we look at which specific regimens, this was an era really before the onset of immunotherapy, so that wasn't affecting costs either positively or negatively. But I think that when we looked at not using the combination of pemetrexed plus bevacizumab with carboplatin in the first line setting, I think stepping away from items like that, and it's not because any one of those drugs individually is not indicated, but as a combination, as you know, based on the Point Break study and the Pronounce trial, really recognizing that combination probably wasn't adding additional value, but was doubling the cost compared to whatever reference regimen you wanted to look. When you compared to carboplatin, paclitaxel, bevacizumab, it looks like outcomes were similar. Toxicity was not dramatically different, but there was a major cost savings.
Yeah, and as you're aware, we did a similar analysis here at the Cleveland Clinic showing that sort of change can make a big impact on cost. So I think that's very impressive. The window of time that you had for your study was perfect because, starting in 2015 and 2016, we've now got the issue of immunotherapy coming in, which is going to make it hard to compare the current treatment landscape to previous years in terms of cost. So it was a nice window to be able to show that this kind of a pathway can improve that per patient cost without impacting survival.
Indeed, we did kind of look into that from a timing standpoint. But, I think part of it, too, is recognizing that while obviously these external forces are going to affect cost in dramatic ways, part of what pathways are trying to be, it's trying to be the water cooler where we have conversations about what we should and should not be doing. As new agents come to bear, whether it's necitumumab, whether it's nab-paclitaxel, it's a chance for us as an institution, as a network, to sit down and say, what role, if any, should these newer agents play in our paradigm for care?
And so going forward, so you mentioned that there are some limitations because you weren't able to capture 100% of the costs involved in all the patients in the study. What do you think needs to be done if you wanted to do this in a more comprehensive fashion?
I think ultimately you really want to get at total cost of care. You want to get at things like ER visits and hospitalizations because those are going to be big drivers in cost. I think that in addition to whatever costs and usage you can get from your own organization, that ultimately it's going to require some collaboration with payers to try to get to all of the costs, because you can never really get it for anything that happens outside of your institution. Patient shows up to an ER outside of your network, you're not capturing that. Patients fill their erlotinib prescription through CVS Caremark, you may not be capturing that. And so if you really want to capture everything, you've got to collaborate with payers to try to get at usage and cost data. We're trying to do that. We're collaborating with some of our major payers in our state to try to get at some of this information to see if we can do better.
And so I'm sure there are a lot of institutions out there who up to this point haven't really invested a lot of time and effort into creating their own care pathways. And given the experience you've had being in this from the beginning, what advice and what lessons learned have you had that you'd give to someone who wants to implement clinical pathways for their own patients?
I think there's a few pieces to it. One is, at least in terms of developing your own pathways, and I know that your organization has done this as well, it's a tremendous amount of work, and I think a lot more than we had anticipated initially. And so, appreciating that, making sure that you are staffed up to do that is critical, because otherwise it'll sneak up on you and you'll find that you're not able to meet your deliverables in a timely fashion. The other piece is not just creation, but implementation, no matter what pathways you decide to use, whether it's homemade pathways or whether it's some commercial product, recognizing that you've got to get your providers invested. You've got to get your providers on board with the fact that this is going to happen and combat any resistance along the way, whether it's resistance to workflow and IT, or whether it's resistance to the notion of feeling like you're being told what to do by a computer, even when you yourself are helping to create that computer system.
Yeah, that completely echoes my own experience with having to create pathways. Is the engagement of the people who will be using it in the whole process seems to me like the key aspect that perhaps doesn't get enough attention.
I think that we are proud that we're echoing things that you had found as well. I think as we look at this more and more across other diseases, hopefully we'll get similar messages.
Dave, thanks so much for joining me today to talk about your paper. I think this is a really important topic that's going to engage a lot of our listeners, since they'll be, if not dealing with it now, dealing with it soon.
Nate, thank you so much for having me. It's always a pleasure to talk with you.
And I also want to thank all our listeners out there who joined us for this podcast. The full text of Dr. Jackman's paper is available at ascopubs.org/journal/JOP to be published online in early March 2017. Don't forget that you can read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journals mobile app, available in the iTunes Store and Google Play. This is Dr. Nate Pinnell for the Journal of Oncology Practice, signing off.